Welcome back, everyone. We'll jump in and get started. So I have Dr. Sinaraja here to introduce the next set of presenters. So over to him. Sorry, you can't see.
Thanks very much. So thanks, everybody. Thanks to the department for the invitation. My name is Aingaran Sinaraja. I'm a palliative care physician and the division head for palliative care at Lakeridge Health. But today I'm here in my role as the Pathways medical lead for the Durham OHT. And in that role, I'm also here representing Lake Girton, who's the co-lead of that ICP, Integrated Care Pathway, with me with Durham OHT. And February is Heart Month. We're just catching it at the end of the month. And so we thought it would be a great idea to talk about CHF and updates around that. And so we have two great speakers today to go through heart failure and some updates around that. Just an FYI about the statistics of heart failure in Durham region. We do have a higher prevalence of heart failure in Durham compared to the province. So it is an important disease, chronic disease that we need to be mindful of and look to improve on. And you can see here that some of the rates around readmissions in 30 days after heart failure, hospitalization, and same thing with emerge visits. We are the blue line on the bottom there, and we're sort of around the same marks as the province and other OHTs. Even though there was a period where we went a little bit higher in the last sort of 2-3 years ago. And so we'll present today on one pathway-related intervention called Best Care that we'll hear about, and then some clinical updates from one of the cardiologists. So we're just going to give this a try around Menti to get a sense from you around what your knowledge about CHF is. We're just going to see if it works. So bear with us. And you can use the code at the top. So the code is actually updated now. So don't use the slide code. It is 16551236. Go to menti.com and you can start inputting these answers. So some, again, it's not, so some of you have talked about them needing to come to the family doctor despite having cardiologists involved. How do we keep it under control in terms of exacerbations? How do we diagnose diastolic dysfunction? How do we manage in primary care? Keeping CHF under control, good. All right, so let's go to the next question, and I'll have to figure out how to go to the next question. Yeah. I can't see it on my screen here, so I can't get to the arrow. Sorry, folks. Oh, like, the arrow, the actual arrow. Okay, so thank you. So here's the next question, and it should go forward on your side as well to this next question. So please answer how confident you are in classifying the various CHF stages. And we'll see how the group thinks and how you think after you hear the updates. So a mix of agree and disagree and not sure, I don't know, neutral. Few more neutrals. Okay. All right. That should be everybody, I think. So the next question, and there's only sort of three more, so don't worry that the whole session will be on this. I'm familiar with the latest updates around the heart failure with the reduced ejection fraction. Okay. A few more disagrees here. Okay. Good. Next is around this risk stratification tools that could help with sort of prognostication and management of CHF. Okay, so a bit more disagrees here as well, it looks like. Thank you. All right, and then this is the last question, I believe. So optimizing the titrations to reduce hospitalizations, and I guess reduce visits. That's one of the needs I saw because their CHF is more optimally managed. And it looks like we are letting you guess what the answers are. It just says item 1, item 2. So apologies for that. We will take that probably to be neutral. So let me just move on with this one. So, oh, and then sorry, so this would be the one after that. So we'll come back to this later. So let me just present my slides again. Perfect. All right, so it's my pleasure to introduce our first presenter, Madonna Ferron. She is the director of the Asthma Research Group in Best Care since 2007. She has an interest in chronic disease management, research and evaluation initiatives, and health system transformation. And so she will take us through what Best Care is all about. And then the second speaker we have after that is Dr. Andaleb. He completed his undergraduate studies and Master of Science degree at McGill University. His focus is on cardiac arrhythmias. He did some advanced fellowship training in interventional cardiology at Beth Israel Medical Center in Harvard, in Boston, and then came back here. He is a member of the Lake Ridge Health Team. He's the cardiology site lead in Oshawa. And he also holds an adjunct assistant professor of medicine at Queen's University, and also works out of St. Michael's Hospital. So the objectives for today are to provide physicians with that update on CHF diagnosis, assessment, and management, review the guideline changes, learn about risk stratifications tools, and then how to overcome some of the implementation of this best practice CHF, which is what the CHF is about. So just quickly, my disclosure slides. I do have some honoraria from the Canadian Society of Palliative Medicine and some research grants, and then I am paid for my roles with OHT, Queen's, and Lake Ridge Health. So without further ado, over to Madonna. I believe she's online. I'll hand it over to you. And I can advance the slides.
Thank you. I think you guys have the slides. You'll be advancing them, correct?
Yes, I can advance
Okay.
it. Thank you.
Okay. So if we want to go to the first slide. Great. So I'm going to go through a lot of information very quickly, but I want to explain what Best Care is. And we are a chronic disease model of care. We're not a program where you see patients for, 30 days, 6 months. We are a program that was created by primary care for primary care. Maybe next slide. There we go. Okay. We are a not-for-profit. We are not connected to pharma. We are not connected to for-profit. The majority of our funding comes through the Ministry of Health. And we do research also. So I just wanted you to know that we are operated by a community board of governors and a not-for-profit. Next slide. So I just want to share with you, I mean, we have a problem in the health system, and this model of care has been around since 2002. So this isn't something that we've created overnight. We have been doing this work for over 20 years. And we're doing this work because of the healthcare system. We know that the majority of patients are actually managed in primary care. So there's a bottleneck up to specialty care. So our goal was to bring resources to primary care, but resources where the family physicians and now the NPs over the last 10, 15 years had confidence in this person. They know it's guideline-based care that we're giving, and they become the experts in care. So we had some key challenges here, hospitalizations and an endless cycle of that. We have some great guidelines, but nobody's actually putting them in, or some are putting them into care, but many are not. So these are the approaches that we took. We wanted primary care to be the foundation of the care for our patients and what we were doing. And we wanted to bring guideline concordance to life and kind of walk the walk. And we also actually have brought team care in to teams that have team care. We've elevated what they have done, but just remember, we've been doing this since 2002. There was no team care even out there. More than half, we are in 400 clinics across Ontario. More than half of our clinics are not team-based care. They're physician offices with not attached to team-based care. Next slide. So I won't go through all the gaps in care. Everybody feels it and knows it, but there is a lot of gaps in care that we have been addressing. These slides can be shared, so you're welcome to have them. But again, one of our biggest gaps is to get that resource out into primary care and to actually evaluate what we're doing. And we have 26 peer-reviewed publications on Best Care Program, and we have a few more going. So we have really taken what we have done to actually evaluate and see if it works, and we have a very robust quality assurance program. We're not a pilot program. We don't have that pilotitis like what seems to happen in our healthcare system. And the rest I've kind of gone through. So next slide. So what is our approach? We're a chronic disease model of care. We are a platform for multiple chronic disease. Today, we're going to talk about heart failure. I'm just going to dabble a minute in COPD because I just want to show you the full direction that we have published there. We're doing the exact same in heart failure and just the overall program, but I will focus on heart failure. And I've talked about being an instrument in primary care and health system transformation. So what are we? We're a complete knowledge translation interdisciplinary program. How do I know that? It's a knowledge translation from both sides. We have specialists. So Dr. Bob McKelvey, he's a heart failure cardiologist, used to lead the guidelines. He is our medical director for heart failure. We have Dr. Christopher Lishka, who is our medical director and CEO for anything on the respiratory side. We're actually in the middle of finishing up a CKM program, and we're working with endocrinologists and some internal medicine experts in that realm also. So we're working very hard on that knowledge translation to primary care, and our primary care docs will say that I have become a better respiratory or COPD or heart failure primary care physician, because after my best care case manager constantly talks to me about, we need to do this, this is why it meets the guidelines. And here's the research to show why we're doing it. And these are the meds and why we're asking it. When you hear it, it's experiential learning right on the job versus CME. And then, of course, we're learning a lot about that care. It's holistic care. It's in-person, evidence-based, but it's person-centered care. That is the new lingo nowadays, but we've been doing person-centered care since 2002. What do? We embed a trained, certified chronic disease educator case manager. It's more than education. We have a huge focus on medical management for patients, and we deliver comprehensive guideline concordant care. So we're thinking about diagnosis, we're thinking about medication optimization, care coordination. It is an upstream approach. We are trying to get to the sickest patients before they land back in the hospital or land back in emerge, but we're also managing these patients before they get into the healthcare system of the hospitalizations. We support system transformation and primary care foundation. I will talk about the day-to-day in a minute. Next slide. So I'm just throwing out, showing you the multi-disease, heart failure, COPD, asthma, AFib. We've been doing heart failure since 2006. We have actually finished a randomized control study, the first of its kind in Canada, with 100 physicians that have participated with us. We're just about to finish off getting our publication on that. But we also did pre-post analysis. So we always start with a pilot type of work. We did a pre-post. We published that also with very, very positive results on medical management and on health service use and quality of life for patients. But this just shows you there's more than just dealing with COPD or heart failure or of a patient. They have there are multi diseases that we are working on with one single patient. And vaccine is very, very important with heart failure, and it's a key component to what we do. And lung cancer screening has been new since 2025. And like I say, we're now working on a full CKM module. Next slide. So I just wanted to give you an idea of what best care is. Next slide. Let's just talk about the impact, and then, I'm not going to go through these. This is, if the slide deck is shared, there's just some impact of patients and providers. Next slide. So I just want to set the stage for where we're going with heart failure. I did tell you about our cluster. It's actually a cluster randomized control trial, but I just want to show you something about COPD. So next slide. With our program, we have the capability, we have lots of data. Last year, just to give you an idea, we saw 21,000 patients in Ontario. We actually have grown into Quebec. I have 8 case managers in Quebec and British Columbia. So people are really seeing the value of what we have been doing. This is just to show you there is a lot of things we can look at to see how are we doing with the medical management for our Gold E patients with COPD. And at the end, you can see it went up almost 30% of an improvement of what when we first initially saw a patient. So I just wanted to give you, we're doing the same thing with heart failure. Next slide. I know my time's limited, so I'm going very fast. In COPD, we started with a randomized control trial, one of the first in the world. There's only actually 3 that have been done, to my knowledge, in primary care. Significant improvements in their quality of life is what I'm showing you on the left panel. But I want to just let you know, this was done in 4 family health teams. This was done in team care setting. So we are comparing to what is kind of the gold standard, and there was actual progression of the disease with patients we did not see as compared to patients that we saw. On the right panel, I'm super excited about this. We published this in 2024. This is, so we can't live in a randomized control trial world. And this is something we're going to be doing for heart failure at a certain point. This is an interrupted time series analysis. This is ICES data. This is OHIP data. This is not my data, but these are our patients from Best Care. Just shy of 2,500 patients. If you look on the left panel, or so the left side of the zero line, that is 3 years before they have seen anybody in Best Care. And COPD, you can just see the progression worsening and worsening and worsening. Each dot is a rate of hospitalizations. It significantly increases. Then once they're in Best Care, not only does it drop significantly, 50% drop after 12 months, and within 3 years, a 72% drop in hospitalizations. We have changed the trajectory for these patients with COPD. Now, if you look at this, we have the exact same patterns for ED visits, cardiovascular events. We have the exact same pattern, and physician visits. Big significant drop in the Best Care program. Next slide. So I just want to show you one slide because I want you to kind of know that this is not just a heart failure. We're going to not just look at care of heart failure patients. We're going to look at everything. I just want to show you one slide on the lung cancer. Next slide. This is being done on every single patient that is at risk for lung cancer. In Ontario, their rates for lung cancer screening were very low in primary care. So this is just showing you from a system perspective, we have increased. This is we have sent over 35. We have assessed 3,500 patients for lung cancer screening, and we're only sending the patients that are at a 2 or higher % risk. Now, this is an enriched population with COPD, so of course you would expect their risks to be higher. But if you, for anyone who knows any what this risk calculator is, if they're 2% or higher, that means they have that risk of getting lung cancer in the next 6 years. And if you can see, we have lots of people that are over 10 and higher. The average risk in our population is over 10% risk, which is huge. So we are now able to collect the data and see that we are reversing patients from, instead of getting a lung cancer diagnosis in stage 3 and 4, it's actually being reversed where we're catching them earlier in stage 1 and 2. So this is being done on heart failure patients. If they meet the criteria, this is being done on those patients also. So just to show it's not just we, are narrow-minded to heart failure. Next slide. So let's talk about our heart failure and our impact of what we've done to date. Next slide. So this is our pre-post analysis. And by the way, this is also includes, and we do have this all divided out in the paper. We have a training ground with a heart failure specialist. It's part of our program. And we see their patients in this clinic. So they are included in here. And what we've learned is, even being seen by a specialist, patients are not being optimized or titrated to target, not only not in the time frame, but not at all. That is not meant to be a negative to specialists. They do amazing work. It's a time. They don't have time. They can't see patients over and over, and we need to get them titrated within 6 months, and that takes time and takes visits. But the family physicians don't have the time to do that either. And that's where we see the Best Care case manager can be the quarterback within the system to see these patients under the supervision of primary care. But I want to share with you, you will not have the burden of all the work. The family physicians and NPs do not have the burden of the work. We do that, and we have a conversation on what the next steps are, and our case manager takes care of all the work and all the heavy lifting. So if you look on this slide, I won't go through it, but if you can see this is our quadruple therapy. And if you can see on the last slide, at this point, we increased it almost up to 40% from baseline. On baseline, nobody had, they weren't optimized to on their quadruple therapy at that point. Triple therapy, just so you know, was in here because the guidelines had changed during our pilot. Everything at their most recent follow-up had improved in their titrations. In tertiary care, it is my understanding that about 60% of people are titrated according to guideline concordant care, and that's where we are. Our last pull of data, we were at 58%. Next slide. This just shows you, again, it is a pre-post, but we did hit all the confidence interval targets. Huge decrease in hospitalization, ED visits, and improvements in quality of life. And for us, a stable quality of life, you can see that in the right panel, is just as important as improved quality of life. Next slide. So one thing that I heard from you guys that I saw when you were filling out your analysis was the uncomfortable or the disagree a lot for meds, medical management, and guideline directed medical therapy. So let me get back to that. I want to go back to that, but I just want to show you the vaccine and the importance of vaccine. We have a full out vaccine program. So if you just want to go through that, and let's get to what it looks like on the front line. Can go to the next slide. So next one. So how does it, oh, sorry, go back to how the clinic works. So how does the clinic work? You get a case manager that becomes part of your team. That case manager sees the patients one-on-one, spends anywhere between 45 minutes to an hour with that patient, but it's ongoing, continuing care. These are progressive diseases. They don't go away. They see your patients for you. But when they're done with the patient, if there's something that needs to be addressed or managed, the goal is for them to have a 3 to 5 minute conversation with you about the patient. If it's something that needs to be addressed right away, they'll work it out with the family physician and the NP to see what works out best for you. But we really like a one-on-one quick conversation. I did this for many, many years, and our conversations are generally, this is what I found with the patient. This is what's happening. Can we titrate their medications up according to the guidelines? You know, they're reduced, so we need to hit the target of these 4. We look at their labs. We look at their beta blockers. We titrate them. We think about their blood pressures. We think about all of that, and we bring the information to you. You say, yep, that's amazing. Let's say we titrate them. If blood work needs to be done, we send them home with a lab. The lab is done. We look at the lab 2-3 weeks later, and then we continue on the titration or stop. But it's a triad of care. It's the primary care provider, the case manager, and the patient. So our family physicians and NPs know everything that's happening. But there is an integration with secondary care in many areas, but I'm gonna use North Bay. We have a cardiologist there. A lot of times he will write a full note of what he wants done from a titration perspective and how to go about it. And then he'll see them in 3 months or 6 months. And our best care case manager, under the supervision of the primary care provider, will do that work so that when they get back to seeing the specialist the majority of that work is done, and the specialists can do what they do, take care of the sick and see the less sick less often. In preserved, we're doing exactly what we should be doing with preserved. It's just not as clear cut with the four meds, but with SGLT2s and other things that have come about, we are working within those guidelines of how to manage the preserved. What we did learn in our randomized control trial was actually the preserved patients are the ones that are landing in the hospital more and emerge more than the reduced. We had to open up our criteria because what we found is the reduced are seeing the specialist more and having less hospitalizations. That was our experience in Southwestern Ontario. I'm not speaking about your area. And then the patient is booked in for follow-up. So there's an ongoing follow-up, and we have decreased the burden on family physicians. I can't measure it for, well, we do measure it for NPs, but with the ICES data, we have decreased the family physician capacity by 70%, meaning they don't have to constantly see these patients over and over. They can do other things with their time to see patients that need them, but they're still overseeing the care. So maybe I'll just stop at that point. Can you just go to the next slides? This is just for your knowledge for the OHT. This is just how we're supporting, oh, next slide. I left that in if you're going to share the slides, but this is stuff we are working with primary care. In a primary care in Middlesex, London, just to give you an idea, when we started this back in 2020 with them, our specialist said, I'm not sure primary care, And when we looked at the data, there's 11,000 patients with heart failure, and the specialty clinic sees between 500 and 700 patients a year. So we kind of work together with the specialists to help really grow this in that area, because there is no way specialists can see all of these patients, but they need to be managed. So we need to build the confidence with primary care. And that's what I'm hearing from you, from what you answered. We can help build your confidence with class severity, with guideline-directed medical therapy, with when to diagnosis. But a lot of times they need to be sent to specialty care for etiology and maybe some guidance, but do they need to just be managed under specialty care? So we're working really hard with that integration between primary and specialty care, decreasing health service use and our capacity on our family physicians. We know we're improving provider experience. I can tell you because we've measured it, and I have lots of testimonials on it. Next slide, and then I'll wrap up. I'm pretty sure I just wanted to show you last year with our data, we have 2,200 primary care providers that we work with. That is active numbers day to day. That is not a fake number that I saw one of their patients. These are active physicians year to year that we are seeing their patients. And like I say, we saw 21,000 patients last year. And this is just a snippet of where we are in Ontario. I didn't show you Quebec and BC. Next slide. So just to wrap up, we are a proactive upstream guideline directed, proven, and evidence-based. We were actually at there's a piece that big I forget what it's called, across the world business conference. There's actually an excerpt about best care in the healthcare division that should be done globally. So we're really excited about that. We're working really hard to get this model of care, but the level of integration and the level of evaluation. We have a return on investment 4-to-1, and we are now doing this is with health economists that we have been working with. We actually just submitted another publication that actually shows for COPD, we have decreased their health service use across a 25-year span, and their survival rate is higher. It's huge. we're really, really excited about it. I just want to share with you, last year, we prevented 1,100 hospitalizations, 2,400 ED visits. We have decreased our physician hours saved, 6,500 physician hours saved, and we have never lost a physician once they have signed into Best Care. So we're really working hard on the primary care part of the health system. And I do have to go. I had a double commitment here. So I'm not sure if you want me to answer questions now, but I do have Ali on if you wanted to wait until after the next presentation.
So thank you so much, Maron. In the interest of time, I wouldn't mind moving on because I know Dr. Andalib is waiting. And we'll take questions at the end. I know there's one from the audience here. So maybe you and I can connect after. Because one of the questions I have, which eventually I'll try to answer, is how do I get access to this? That's usually one of the questions I have. But I do want to.
So you do have access, and we can work through that. But I'll leave Ali on so she can help with any of the questions.
Sounds good. Sounds good. Yeah,
okay.
Let's do that.
Okay.
I'm going to introduce Dr. Andalib, the cardiologist that I mentioned earlier. He's going to go through some of the clinical updates. I'm going to stop sharing because he has his own slides that he'll share. And let's see in slideshow. And so I'm hoping, Andalib, you can just start sharing and that should work.
Yes. Good morning, everybody. Thank you for the opportunity to present this. I'm just going to try and share. And give me a second. Okay, can everybody hear me and see the slides?
Yes.
Excellent. All right, thanks again. We have a lot of grounds to cover. I'm going to talk fast and, let's try and see if we can finish on time. So we'll get to it. I have no disclosures relevant to this talk. The objectives of the talk are the following: review the epidemiology of heart failure, identify various stages and various clinical phenotypes, review the latest updates on guideline-directed medical therapy for heart failure patients, strategies to reduce hospitalization, and finally, to review the various risk stratification tools available to us. A little bit on the epidemiology of heart failure. Heart failure cases are on the rise. This is data from Ontario showing that the prevalent cases of heart failure increased by almost 26% from 2002 to 2016. As you can see, we're just above 300,000 cases in Ontario alone. That means the cost of giving care to these patients is also on the rise. You can see that this is cost per capita in Ontario again, and there has been an exponential increase in the cost from 2002 to 2016, mainly driven by all the imaging that we have and specifically echocardiography. This is data from United States, a little bit on the projection of cardiovascular risk factors and disease burden by 2060. You can see that you have a projected significant increase in all the cardiovascular risk factors by 2060. And that will obviously reflect in concomitant increase in cardiovascular disease, ischemic heart disease, heart failure by 33% by 2060. So these are, American data. And despite the steep rise in cardiovascular risk factors and cardiovascular disease, the difference between men and women is projected to largely remain stable over time. This is data from North America showing the characteristic of patients that are admitted with heart failure that over time from 2008 to 2018, 2008 is on the left side of the screen. You can see that the age is more or less the same. A majority of patients are in their 80s. there are more female patients than male, but the age has more or less remained the same over time. So for the percentage has remained the same over time. Not surprising to see that the comorbidities, the common comorbidities for these patients are AFib, CKD, COPD, diabetes, ischemic heart disease, hypertension, peripheral vascular disease. And you can see that there's been a rise in admission for HFrEF patients and heart failure with preserved ejection fraction patients over time from 2008 to 2018. Important slide to consider when you have a first hospitalization for this patient with heart failure. The 5-year follow-up is eye-opening, showing that there is the all-cause mortality rate is equal in both women and men, but is pretty high at around above 60%. The in-hospital mortality over, death in hospital over 5 years is pretty high, over 50%. And, all-cause readmission rates for these patients are very high, above 80%. The cost is obviously high, more or less equal in men and women. This is a slide showing that survival goes down as patients get hospitalized. So when you have an index hospitalization, first hospitalization for heart failure, after that, over time, mortality goes high. So this is survival over time, that the survival goes down as months pass after index hospitalization. Important slide. Obviously, readmission rate for heart failure is very important for all medicine departments, including ours. But this is an eye-opening slide to show you that, among the patients that we commonly see, 65 to 84-year-olds, there's more or less about 20%. So that's the yellow bar that you see. These are all provinces in Canada, and you can see that there's the readmission rates more or less is about 20% across the board. So important, obviously, diagnosis. This is just to say that from 2008 to 2018, the mortality ratio is, more or less is still pretty significant. We've done I'd say a reasonable job to try to reduce the in-hospital mortality, but still there's a significant burden for this diagnosis in terms of mortality and obviously morbidity. With that in mind, let's quickly go over to the diagnosis of heart failure. This is very important, especially for you guys, because you guys are the first point of contact for patients. These are some of this is from 2017 guidelines. Obviously, the rest of the slides are from the most updated guidelines. But, just to say that the common symptoms are, dyspnea, orthopnea, PND, fatigue, cough. You got to have a low level of suspicion for heart failure. It's not uncommon that we see patients coming from this clinic to that clinic to multiple ER presentations with a cough, especially young individuals, and they get antibiotics, the puffers, and finally somebody decides to do a BNP or an echo, and we see severe heart failure. There are also uncommon signs or symptoms such as cognitive impairment, altered mentation, nausea, abdominal discomfort. These are more relevant for the elderly. Obviously, at end stage, we have cyanosis or anorexia. So you got to have a low level of suspicion. Obviously, you suspect heart failure. Your clinical history is key. I always tell the residents and students that work with me that 80% of the management of patient is in taking a good history, and very, very important. Physical exam that's getting more and more becoming a lost art, but very important to actually lay eyes on the patient. Look at their JVP, look at their legs. Are they swollen? Look at their abdomen. Listen to their lungs, assess their volume status. And then you do your initial investigations, relevant chest x-ray, ECG, relevant lab works. And if you still have a suspicion for heart failure, have a low threshold to do BNP. And thankfully, we have good, easy access to echocardiography in Ontario. This is a very busy slide. We're not going to go through it in details. We're obviously going to, in a few slides, talk about the various phenotypes of heart failure. point of this slide just to show you, go over briefly the various etiologies of heart failure. And that you keep in mind when you do your history taken from patients. Obviously, it could be in context of arrhythmias, valve disease, coronary artery disease. These are very, very common, most common cause of heart failure. Toxic agents such as alcohol, recreational drug use, some of the alternative medicine medications that people use. Pregnancy state is important. Inflammatory conditions, infections, very important, including HIV in relevant patients. Metabolic conditions, nutritional state, obviously, more and more we think about infiltrative cardiomyopathies, and family history is also key. So important to include in your history taken family history, concomitant illness, prior malignancy, or chemoradiation. Thyroid assessment is important. Travel history is very important. Exposure to chemicals, occupation and occupational hazards, nutritional state, ETOH, and illicit drugs. Obviously, very important to clarify in your history taken. Role of primary care physicians and primary care providers is key in all aspects of heart failure care. Prevention, optimal management of risk factors, risk stratification. Diagnosis is very key, like we talked about. When patients are diagnosed with heart failure and they hopefully become in a stable heart failure state, very important to follow them. And we just heard an excellent talk by various approaches to try to keep these patients stable and out of the hospital. And obviously, recognition of when to refer these patients back to hospital or to more advanced settings. And very, very importantly, to discuss end-of-life care, because when patients have getting close to end of life, and have an open discussion about palliative care, which is a very, very important topic. Now, let's move on and talk about various stages and clinical phenotypes of heart failure. This is a slide from ACC guidelines, various stages. This is a ACC AHA classifications of various stages of heart failure. Very important to be familiar with them. So stage A, ACC classification for heart is patients that are at risk for heart failure. So they have the typical risk factors: hypertension, obesity, cardiovascular, ischemic heart disease. They've been exposed to cardiotoxic chemo agents, but they don't have documented heart failure both by imaging or chemical biomarkers or by symptoms. Stage B is pre-heart failure, meaning that they have evidence either by imaging or chemical biomarkers of structural heart disease, but they're asymptomatic. And obviously, sometimes it's hard to elicit, but so this is the definition of stage B. Stage C is when we intervene with our guideline-directed medical therapy, is for patients who have symptoms in presence of structural heart disease. Stage D is patients who have advanced heart failure with multiple hospitalizations despite guideline-directed medical therapy that's optimized. Very important to be familiar with the New York Heart Association classification of heart failure, NYHA. Class 1 would be no limitation of physical activity, no symptoms essentially when they're doing their physical activities. Class 2 would be slight limitation, so not being able to walk 5 blocks or a couple of flights of stairs, so mild symptoms. Class 3 would be marked limitation, comfortable at rest, but they go from one room to the next and they get symptomatic. And Class 4 would be symptoms at rest. So let's talk about various phenotypes. The top is from ACC guidelines, bottom is from ESC guidelines of classifications of heart failure. So you do your echocardiogram, you get a left ventricular ejection fraction. So HFrEF, or heart failure with reduced ejection fraction, is defined as LVEF of equal or less than 40%. And with all of these patients, they could remain the same or they could improve. Heart failure with improved EF. And if you have heart failure with mildly reduced EF, the definition is EF of 41 to 49%. Again, when you follow them, they could remain the same, improve, or get to normal. And then you have the heart failure with preserved EF, defined as LVEF of more than 50%. And then, similarly, when you follow them, you could have various outcomes. These are relatively well aligned with the ESC guidelines. And, I think by now we're all familiar with HFrEF, mildly reduced EF and preserved EF. Now, CCS, Canadian Cardiovascular Society, in an effort to make management of these patients easier, they've sort of lumped the MEF and HFpEF into one entity called heart failure with non-reduced EF, or NRF. I don't say I love. I've got to say I don't love the naming, but for this is what is recommended right now by Canadian guidelines. So we have the HFrEFs less than 40% or equal to 40%, and the non-reduced EF. So with that in mind, let's now review the guideline-directed therapy, pharmacological therapy for HFrEF patients. Following slides are from the 2024 ACC guidelines, which is the latest guidelines we have. So very, very important to get these patients on the 4 pillars of guideline-directed medical therapy. That's the RNA angiotensin receptor neprilysin inhibitors, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors. And the goal is to achieve optimal 4-drug guideline-directed medical therapy no longer than 3 months. Obviously, in real life, there's a lot of issues, especially in the low socioeconomic patient population that we deal with. But the goal is to get these patients as soon as possible on all these patients, all these drugs, ideally no longer than 3 months. So if patients are on these drugs and they still have class 2 to 4, obviously you would titrate to maximum tolerated dose. You use diuretic agents to get them out of trouble, which is, really, that's the best therapy we have to make patients better, even though it feel better, even though it doesn't, change their outcome. If patients, especially African-American patients, if they're on guideline-directed medical therapy and still have class 3 to 4 symptoms, there is a role to add hydralazine and isosorbide dinitrate to these patients if their blood pressure allows. So very important to consider. Ivabradine is another medication to consider. We'll talk about that for patients who still have class 2 to 3 symptoms. They're in sinus rhythm, they're on maximum tolerated beta blockers, and they have a heart rate of more than 70. That's mainly to reduce hospitalization. And we also have another class of drugs that we normally don't commonly see or use. I have never used it myself, or called vericiguat, is in the guidelines. And we reserve that for patients who have, worsening heart failure with multiple hospitalization and on the 4 pillars of guideline-directed medical therapy already. So let's talk about ARNI. That came to light based on a randomized clinical trial called Paradigm HF. These are reserved for patients who are class 2 to 4 heart failure in conjunction with background GDMT. You replace ACE inhibitors. Very important not to start them within 36 hours of last exposure to ACE inhibitors. If you have a history of angioedema, you don't want to start these drugs. In pregnant patients or patients that are breastfeeding, you should not start these. And if somebody has severe hepatic failure in Child-Pugh class C, you should not consider these drugs, or if they're on a renin receptor blocker. If you have significant reduced GFR less than 30, these patients were excluded from the clinical trials, but you can use these drugs. You have to follow them closely and make sure you don't run into problems with further reduction in GFR or hyperkalemia. Please do not stop the drug. It's okay to see up to 30% rise in the kidney, in creatinine, but you have to follow them closely, make sure they don't continue to deteriorate, and make sure you don't run into problems with hyperkalemia. Patients who are hypotensive, it's difficult, obviously, to start these drugs right off the bat. If you cannot start the ARNI, then you consider ACE inhibitors and ARBs. These are the top, the bottom right are all the ACE inhibitors and ARBs that are studied in clinical trials, and the doses and the maximum dose that you should try to achieve. On the top right of the screen, you see the mechanism of the renin-angiotensin-aldosterone system and neprilysin and antagonist system to improve outcomes for these patients. We're not going to go over them in detail, but if you cannot start ARNI, at least get them on ACE inhibitors or ARBs. MRAs are very important. 2 MRAs are approved for HFrEF, allopurinol and spironolactone. Spironolactone obviously is cheaper, but it comes with the potential side effect of gynecomastia and impotence. It works via various mechanisms to improve outcomes, both in terms of mortality and hospitalization. SGLT2 inhibitors are very important. They're not just souped up diuretic. They act via various mechanisms to improve outcomes. This is a very busy slide in the middle. I'm not going to go through all of the various mechanisms, but they act in various ways. So again, if you have a class 2 to 4 patients, you definitely should consider these drugs. They're not approved for type 1 diabetics. If you've had a hypersensitivity reaction to these drugs, obviously you want to be careful with them. Somebody has a EGFR less than 25, you can probably consider Jardiance or empagliflozin up to 20, but you got to be really careful. If somebody has had multiple recurrent UTIs or yeast infections, got to be careful. And what you don't want to see is potential necrotizing fasciitis of the perineum, or Fournier's gangrene, which is a very, very rare but serious life-threatening condition. Somebody's going for a important surgery such as cardiac surgery, important to stop these drugs 3 days before the surgery. Beta blockers are also another, the fourth pillar of the therapy. The bottom is the 3 beta blockers that have been studied in clinical trials: bisoprolol, carvedilol, and metoprolol succinate, which is only available in Canada at a dose of 100 milligram. So that's a once-a-day drug. We don't have it, again, commonly available in Canada. What we have available is metoprolol tartrate that, I normally don't go out of my way to change it in patients who are stable, but if you want to initiate, it's better to initiate bisoprolol or carvedilol. Again, the top right is the various mechanisms that beta blockers act to improve outcomes. We don't go over all of them, but there are multiple mechanisms that beta blockers to improve outcomes. Diuretics are obviously important. The first line of therapy to get patients out of trouble. They don't affect mortality, but make patients feel better. If you're going up on the doses of furosemide to more than 80 BID, you've got to consider alternative loop diuretics such as bumetanide or torsemide, because of better and they have better oral bioavailability, or use, for example, metalazone, which is a thiazide-like diuretic, in conjunction with the furosemide, or use a diuretic in conjunction with the furosemide. We talked about hydralazine and isosorbate to consider for patients who are in class 3 to 4 heart failure that are already on GDMT, and especially in African American population. And again, this is to reduce hospitalization. Ivabradine is a sodium, literally called funny channel blocker, which reduces the heart rate. There has been data showing that it improves outcome by reducing hospitalizations in patients who have a EF less than 35% and class 2 to 3 heart failure in sinus rhythm. Important to be in sinus rhythm with a resting heart rate more than 70 beats per minute, our maximum dose of heart failure. So if you have somebody with sinus node dysfunction or conduction disease or prolonged QT interval and a heart rate less than 60, you don't consider these drugs. Vericiguat is a guanylate cyclase stimulator, is a drug that works similar to NO, and we can consider it in patients with an EF less than 45% on maximum guideline therapy. And it, again, works in various ways to reduce outcomes. Very, very important for you to consider and identify is iron deficiency in patients with HFrEF. 50% of patients with HFrEF have iron deficiency, regardless of presence of anemia, and we should screen for it. So get ferritin and iron profile. If you have ferritin less than 100, you have the diagnosis in between. If you have a TSAT of less than 20%, you have iron deficiency. And major guidelines right now recommend ECS is a class 1 indication to replace iron IV to reduce hospitalization, make patients feel better, improve LVEF. We haven't seen improved mortality, but with everything else, there is definite improvement in how patients feel, and so very important to consider. Again, it's a class 2B in American guidelines, a class 1 indication in European guidelines. So regardless of anemia state, and IV is the preferred mode of repletion of iron. So oral iron is generally poorly absorbed by a GI tract when you have heart failure. So you got to use IV in a formulation. The ferric carboxymaltose formulation is the potential recommended formulation to use. Digoxin, brief note on digoxin. Again, you got to respect this drug. It's not for everybody. And if you have an elderly patient with CKD, you gotta be careful and know how to use it. So it's a class 2 recommendation, especially for patients who cannot tolerate GDMT, have a low BP, and normal creat, you could consider them, or patients who have atrial fibrillation. Very useful drug to use if you know how to use it. And you start these patients on therapy. You want to follow with a repeat echocardiogram in 3 months to make sure to see what you've done with your therapy, and then how to follow the patients later. This is a quick slide just to show you that there are reversible scenarios for HFrEF patients that might merit consideration to downgrade therapy down the road, such as tachycardia-related cardiomyopathy, ETOH-related, chemotherapy-related cardiomyopathy, peripartum cardiomyopathy, or valve replacement surgery. Okay, let's quickly talk about non-pharmacological therapies for HFrEF. This busy slide just to let you know that after 3 months, you reassess EF. EF is still less than 35%. You have a patient in sinus rhythm, left bundle branch block, and a QRS duration more than 130 milliseconds. You got to consider them for CRT or cardiac resynchronization therapy, which has shown outcome benefits. ICD, we need updated data on this, but we still have to refer these patients to electrophysiologists and heart failure or cardiologists to consider. We should probably have better ways to identify patients that would benefit for primary prevention. But for now, important to recognize at least the need for it. Revascularization is key. Ischemic heart disease is one of the most common causes of HFrEF. There is data showing that, long-term data showing that CABG in presence of heart failure with reduced EF and significant 3-vessel disease has mortality benefit after 10 years. We have not seen that with PCI, so we reserve PCI or percutaneous intervention for patients with refractory angina or patients that are high risk and unsuitable for CABG. So again, so the guidelines recommend CABG as a first-line therapy for patients who have severe 3-vessel disease and HFrEF. PCI is reserved for patients for refractory angina. You don't need to manage these patients on your own, but be familiar with the concept of if you have somebody with significant MR, functional MR, which is related to LV dysfunction and symptomatic despite GDMT, you can consider MitraClip. Triluminate trial is a very imperfect trial, lots of discussion, but just to let you know that if you have somebody with severe symptomatic TR despite guideline-directed therapy, there is potentially a role for transcatheter repair of the tricuspid valve, and with a trial that's shown improved quality of life. Exercise is key. Get your patients to exercise. We got a systematic review showing that exercise reduces hospitalization and improves quality of care for these patients. So I'm going to move a little bit faster for sake of time. Let's move on to our heart failure with non-reduced EF pharmacological therapy. This is especially with the HFpEF patients, as opposed to the HFrEF, which is the problem is with the heart. HFpEF is everything else. These patients have metabolic syndrome, they're older, they have COPD, they're obese, they have coronary disease, atrial fibrillation, hypertension. So there's everything else that's wrong with patients. And it's not just the heart. So really, it's been very difficult to come up with mortality outcome in terms of therapies that we have for these patients. So really, you got to focus on managing all the risk factors. Obviously, diuresis is key to get these patients out of trouble. Non-pharmacological approaches, teaching them about self-care, volume status, exercise, and management of the risk factors is key. But now we have strong recommendations to start SGLT2 inhibitors and MRAs in these patients, mainly with reduction in hospitalization. And in specific scenarios, such as if you have a patient with an EF of 45% and above and a BMI of more than 30, we should consider GLP-1 agonist. And we see them more and more. Ozempic will become generic in Canada, one of the first countries in the world that will have that as a generic option available. And then we should consider ARNI or ACE or R, specifically candesartan, if blood pressure remains more than 100 and there's low risk of hypotension for these patients. There are various options for MRA, spironolactone, eplerenone, and finerenone. Finerenone is very expensive. It's a non-steroidal MRA that could have its use, but obviously you have to keep in mind the cost for these patients. This is the slide that tells you the starting dose and what to titrate for. Obviously, we got to be careful with hyperkalemia and reduction in GFR. And this is a slide showing you that we have the semaglutide or Ozempic and tirzepatide or Mounjaro that are recommended to consider in patients with EF of more than 45% and BMI of more than 30. Very useful drugs. Obviously, patients are obese, you get them leaner, they feel better, and I wouldn't be surprised if you see all kinds of cardiovascular outcome benefits. Let's move on to what we can do to strategies that we can reduce heart failure hospitalizations. It's a multidisciplinary approach. Most importantly, get these patients on 4 pillars of GDMT, the HFrEF patients, as soon as possible, as fast as possible, maximum dose tolerated. And you gotta do, the best time to do it is when they're in the hospital. And we have randomized clinical data showing that it's safe. Avoid unnecessary dose reductions. Most of the time, patients go see their primary care physicians, and there's a little bit of rise in creatinine, and they stop the ARNI. We should try to avoid that unless you see more than 30% rise in creatinine or significant hyperkalemia more than 5. Don't be stressed. Just follow them closely, and obviously it's difficult to follow yourself, but hopefully, with pathways, as we talked about before my talk, we can facilitate these. Early and aggressive titration is key. Diverse heart failure programs are key. We heard the talk before me, and we also have nurse practitioner run heart failure service at our hospital, which has been a great asset for patients. And we have data showing that we've reduced hospitalization for patients. They're a very valuable tool, and now they actually work with paramedic to go and do home visits for patients. So a team-based care approach would be key to have cardiologists, primary care specialists, and specialized nurses, nurse practitioners to collaborate all together. It'll be important to know how we can all collaborate, because I also don't know how to use the services of the best care that we just heard before my talk. So patient empowerment and education is also key to prevent recurrent hospitalization. There's also a role for monitoring, remote monitoring. So, you know, you can just basically ask patients to get a scale, blood pressure monitor. You know, there's more complicated implantable hemodynamic sensors as well that we don't get into. But we also have a structured remote monitoring program currently run at our nurse practitioner service. And we're in talks with Toronto General Hospital to see whether we can utilize their system that's supported by the government to sort of remotely monitor these patients. Patient education is key. Again, you know, let the patients know they got to be familiar with, you know, their symptoms, daily weights, sodium restrictions, lifestyle advice, and medication adherence. It's very important. We have various tools that teach patients right now about their medications and you know, their avenues for support. So again, early follow-up for hospitalized patients is key. That's exactly what we do for our nurse practitioner heart failure program. So within 7 days of follow-up would be beneficial for patients that are discharged from the hospital, and you know, risk stratifying higher risk patients to monitor closely. We'll talk about that in a couple of slides. Again, in summary, optimized GDMT, multidisciplinary program, remote monitoring, patient education, and early follow-up is key. Busy slide just to show you that there are various stages to heart failure. Chronic heart failure, where patients are more stable, clinical risk is low level of hospitalization. You got worsening heart failure, when you have like a little bit more hospitalization, risk goes higher. Very important to identify patients at this level. And then when they get to advanced, obviously risk goes high and there's recurrent hospitalization. Important to detect at the level of worsening heart failure and prevent, like we talked about. A couple of more slides and I'll be done. I know I'm a couple of minutes over time. So risk stratification tools in heart failure. There are various risk stratification tools available. There are long-term mortality tools that are beneficial in terms of risk stratifying patients, and there are risk tools that help us assess, you know, somebody for readmission within 30 days of index hospitalization. And then there are advanced therapy timing tools that we don't get into. So chronic heart failure mortality and morbidity scores, the common scores that are available is, you know, you can use the MAGIC score or the Seattle Heart Failure Model risk score that tells us about 1 year and 3 year mortality. And, you know, they'll help us risk stratify these patients. MAGIC score has 13 variables, and it tells us about 1 and 3 year mortality, and, you know, it validated across all spectrum. This is a sample for a MAGIC risk score that you get. It's available online, and it helps you identify who's at higher risk, you know, more than 39% to be aggressive and refer to a multidisciplinary heart failure team. Seattle Heart Failure Model is another risk score that we can use for 1 and 3 year survival. And again, this is a sample of what you get with the Seattle Heart Failure Model. And we have obviously hospitalization and readmission risk scores, the traditional 30-day readmission scores that are various models that are available, the LACE score, the hospital score, and you know, it helps us guide whom we want to be aggressive and make sure that they're seen within 7 days, and make sure they're followed closely by our remote monitoring and or the Paramed program, and get them on guideline-directed medical therapy as soon as possible. And then you know, we have various machine learning models for readmission as well that are becoming more and more available. Well, I don't get into the advanced heart failure timing tools. That is more of advanced heart failure clinics. Yes, for the sake of time, we're just going to so be aware of the MAGIC and Seattle Heart Failure model risk score for long-term mortality that help patients and yourself to risk stratify these patients. And then we have the discharge and readmission risk models, the LACE and hospital risk scores that help us determine who has a higher risk of 30-day readmission. I want to stop right there. thank you very much. And hopefully you all learned something.
Well, thank you so much, Dr. Andaleb. Great talk with lots of information that you have given us. I wonder whether we should we can switch to questions now. I think there was a question that popped up in the chat there. If you wanted to address that.
Let me see if I can open the chat here. Which beta blocker is preferable for asthmatics and COPD? So very good question. Unless somebody is in a state of asthma exacerbation or a COPD exacerbation, do not be afraid to start them on beta blocker. So essentially, you can use bisoprolol and carvedilol on these patients as long as they're not in a state of acute asthma or a COPD exacerbation. And then the second question, what level of iron, ferritin considered adequate in absence of anemia? So again, it's key to consider iron deficiency regardless of the anemia. So just screen for these patients. All the HFrEFs should get a screening. If you get a ferritin less than 100, you have the diagnosis. If your ferritin is between 100 to 300, then you can certainly look at your TSAT, and if you have a TSAT less than 20%, you should consider IV iron replacement. Did
Thank you.
Answer the question?
Yeah. Any other questions from the audience? Will you be able to share the slides afterwards, Dr. Andaleb, with us?
Yeah, absolutely, not a problem. I can send it. I can send it to you. Is that okay?
Yeah, that's fine. Yeah, just send it to me.
Yeah.
And so to wrap up, I'm just going to switch back to my slides, and I need Sharon's help to move it over to show on the screen.
Sure. Thank you very much for the opportunity.
So thank you so much, Dr. Andaleb. Appreciate that.
Thank you. I think we just do that and then.
So we'll just do some of the survey tools, but in the interest of time, I'll probably just skip it and just go to the slides. And just summarize by saying a big thank you for all of you who came. It sounds like this was the inaugural rounds from the department. So thank you for that. And there's many more to come every month that'll show up. I'm just going to pop up our slide deck that shows the emails of me, but in case it doesn't show up, I'm just going to put it in the slide here into the chat as well. But if anybody has any questions about pest care, about other topics of interest for the future that we should be hosting around disease management and otherwise, please do email me. Again, my email is in the chat there. And there is also, I wanted to highlight that there is a patient-facing heart failure action plan that the region is piloting around standardizing it. So regardless of which community group best care is involved, you can use this. And this is for the patients to figure out what their action plan is. And so you can see here that based on whether they are in the green zone around symptoms or not, yellow zone or red zone, it gives them directions on how to respond to it. So it has things like, if you're trying to get a bit more symptomatic, start up the Lasix, increase the dose of the Lasix. And if you're in the red zone with lots of trouble with breathing, then you need to go to Emerge and 911. And so that's what this action plan is about. It has room for measuring the weight and documenting it, and it's been very helpful. And the nurse practitioner clinic that Dr. Andaleb mentioned, they use this as well. So you're certainly welcome to use it. And if anybody wants a copy of it, let me know and we can send it to you. So my email is there, as I mentioned. Feel free to email us about this topic today, but also just anything in around chronic disease. And also, I'm curious to hear about your thoughts around what a pathway means to you and what do we in Durham OHD and the Primary Care Network need to do around ICP pathways to support family physicians, primary care practices in the region. Otherwise, my part is done, and I'll hand it over to Shannon. Thank you very much.
Fantastic. Thanks so much, everyone. Really appreciate everyone bearing with us as we had, some technical challenges in a new setting here, but I think we got through most of them. I think one of the things we just wanted to ask is if you wouldn't mind, could you please fill out the evaluation form? I will put the link in the chat for those of you that are online, and would really appreciate hearing from you. And also interested in any future presentation topics that you'd like to hear from us. We'd be happy to facilitate those. And then I'd like to invite you back for next time. So as Joel mentioned, this is going to be a monthly series. So please mark your calendars the last Friday of every month. And then so the next one is March 27th, same time, same place. If you come in person, we feed you, and it's more fun to hang out with us and network and socialize. But there will be a virtual option as well. And the topics so far that are confirmed are there on the screen for you to see. So I'll just stop there. If there's any questions or comments or anything like that, as I mentioned, I will email out your attendance certificates. So so FOPLUS, unfortunately, they weren't ready to present on the topic of FOPLUS for next month, although very key. I'm sure people are very eager. We are trying to arrange that, but unfortunately, presenters weren't ready for that date. But yeah, definitely a topic of interest, I would imagine. Question coming through. Okay, amazing. So thank you so much, everyone. Hope you all have a wonderful afternoon and a great weekend. Thanks again.